Okay, welcome everyone. Thanks for joining us this evening for this seminar on social prescribing. We know we may have a few more people join us, but let's make a start. So I'm Kamal Mahtani. I'm a GP and an academic at the University of Oxford, and I'm also a fellow at Kellogg College who are hosting this event today, and my colleague, Stephanie.
Yeah, hello everyone. I'm Stephanie. I'm a health services researcher. Been working in the area of social prescribing for about 3 years now.
Brilliant. So thanks, Steph. So we're going to just chat to you for a little bit this evening about some of the work we've been doing around social prescribing and building the evidence base for it, and how we've built the Oxford Social Prescribing Research Network as well, and what we've been doing within the network. So let's crack on with the next slide. Thanks. So I'm just going to take you for a moment to a time before the pandemic, if we can remember such a time existed. And as a GP, and part of the reason why I'm so interested in this sort of work is around some of the challenges that were facing general practice at the time. So here's some newspaper headlines around some of those challenges. So patients at risk from the length of GP consultations, more patients were having to wait for to see a GP. 1 million patients cannot get a GP appointment. So there were big challenges in general practice in the preceding years to where we are. And as many of you will know, there are big challenges now. And we can talk about some of those at the end of the seminar. So general practice for the last few years in particular has been under huge pressure. Next slide, please. Thanks. And it's not just a matter of the issues around workload in general practice, but it's actually a question of the workload and some of these challenges compromising or risking compromising patient safety. There has been some studies around this, again, pre-pandemic, highlighting some of the challenges actually leading to or being associated with compromising patient safety. So these are big issues that were taking place and are still ongoing in general practice. Next slide, please. So if we start thinking about what are some of the challenges facing general practice and primary care, this has been a very influential document to our group. And it's a document produced by the King's Fund a few years ago in 2016. And it highlighted some of these pressures. And as I said, many of them are still ongoing. The policy document, Understanding Pressures in General Practice, highlighted that some of the challenges included, and you can see here, growing demand, rising expectations. We've got the issues of multimorbidity. So that's when patients have two or more diseases that may or may not interact with each other, but can definitely increase the challenges faced by that patient. We've had challenges with polypharmacy, which is also linked with multimorbidity, whereby patients are taking 2 or more drugs as well, medications. Plus, we've seen increases in social needs. And this is all underpinned, all these challenges are underpinned by a falling or static workforce and a real-time fall in funding, real-time funding. So this is all some of the things that were brewing and ongoing in general practice. Next slide, please. And of course, now we can add to the mix the pandemic, COVID, and again, we can talk about this more at the end of the session because it has again generated huge pressures on general practice, not just managing the pandemic, but also the backlog of patients that need to be seen from issues that were delayed as a result of the pandemic or have got worse as a result of the pandemic. So there's huge challenges in general practice, and many of them have just got worse, and new ones have arrived as well. So next slide, please. So to try and recognise and tackle some of these challenges, the NHS has been working with various other stakeholders on trying to put in strategies to mitigate some of these challenges. And these are examples of some of the various policy documents that have appeared over the last few years. So it started a few years ago with the General Practice Forward View, 2016. Then a similar time, the 5-year Forward View, which incorporated some of the challenges facing primary care. And then more recently in 2019, the NHS Long-Term Plan. And I'm just going to focus a little bit about the long-term plan and how that relates to our work. Next slide, please. So interestingly, the long-term plan was one of the few policy documents from the NHS that started to really well articulate that our health and well-being is actually influenced by a variety of factors, not just our physical and mental well-being, but also our economic environment, our social, and our general environmental status. All these factors come together that can influence our health and well-being. And we, of course, recognize this in general practice. We often see patients for medical reasons, but also for non-medical reasons, which are incorporated. And you do increasingly and rightly so recognize that you're managing a patient in a very holistic way. You're looking at both the medical and the non-medical reasons that they're in front of you, and your support to them for those reasons. Next slide, please. And then one of the ways that the long-term plan talks about how we can support and recognize and then support these wider determinants of our health has come around through social prescribing. And the NHS has made a commitment, and again, this is before the pandemic, but this is something that still remains ongoing, is that by 2023-24, at least, if not more than 900,000 people will be able to access social prescribing schemes in that time frame. And now let's just talk a little bit more about what social prescribing is. Next slide, please.
Kamal.
Thanks.
Yeah, so social prescribing, what do we actually mean by this? It may be a term that some of you are familiar with, but not everyone. So social prescribing aims to address those economic, social, environmental factors that Kamal's mentioned that can affect how people feel physically and psychologically. And that might include things like loneliness, debt, and housing problems. And these issues might first come to light when someone goes to see their GP and starts talking to their GP about their health and well-being. But the GP may not be the only person or the best person to help with those non-medical issues. Social prescribing involves drawing on what we call community assets. So the sorts of things that are listed on the slides here, things like groups, services, organisations that can help with people's non-medical problems. So social prescribing is about accessing non-clinical sources of support, and these predominantly come from the voluntary and community sector. The sorts of things that might be prescribed as part of a social prescription include involvement in arts and craft and cultural activities, befriending services, getting involved in exercise groups or gardening groups, being part of a luncheon club, going to organisations that offer advice on housing or debt, and also volunteering can be an activity that's part of a social prescription. This definition of social prescribing comes from an organisation called the Social Prescribing Network. And this network was set up in the UK to bring together both health professionals, but also researchers, social prescribers, people from the community and voluntary sector, and also interested citizens who were interested in social prescribing. And as you can see here from the definition, there's reference to what's called a link worker. And link workers are people who are employed to be bridges between a health service, the patient, and voluntary and community sector, or those community assets. NHS England in the past 18 months or so has invested quite a bit of money into employing link workers to serve primary care, so to work with GPs and in GPs' practices. What happens in terms of link workers is that somebody may see their GP and the GP picks up that they may have these environmental, economic or social factors that are affecting their health. And the GP may then suggest to the patient that they see a link worker who's attached to the surgery. And if the patient takes that offer up, the link worker then has time to really understand not what's the matter with the patient, but what matters to the patient. So they'll often have an hour at the beginning to really get to know the patient and their needs, and they might see the patient on more than one occasion. And together with the patient, what they'll do is they'll develop what we call an action plan. And this is about how to draw on those community assets to address their non-medical needs. It was the link worker role where our research interest and our research actually began in social prescribing. So one of the first pieces of research that Kamal and I worked on was around social prescribing link workers. And we were trying to understand how the link worker type role has been delivered in primary care. Now, if you want to read more about it, it's been published in the British Journal of General Practice. But just to give you a very brief overview, at the end of 2018, we sent out a survey to all clinical commissioning groups in England. And these are organisations responsible for commissioning NHS services in a local area. At the time, there were, I think, 195, and we got responses from 162. And what we found, as we reported in our paper, is that there was great variation in the delivery of the link worker role across clinical commissioning groups in terms of things like how people were referred. So in some services, it was only GPs who made referrals, but in others, it may be a practice nurse, a practice manager. Some services allowed for self-referral. And also there were differences in who could be referred. So in some services, it was all adult patients, but then there were others where it was only for people with long-term conditions, people with mental health problems, or for older people. And this variation across CCGs was reflected in the number of different terms we got from the survey. So we asked, what term do you use to refer to the link worker type role? And we got over 70 different titles from that. And I think this is an issue because if we want people, members of the public, patients to use link workers, they really need to understand what this role is, who's it for, and how can it help them or a relative. And if we're using all these different terms, that might be confusing for the public. The second piece of work that we've done on the link worker role is what's called a Realist review. And this is a particular approach to bringing together literature. And it's the research that we did, the literature review that we did, was trying to understand how link workers work in practice, for whom and why. And realist reviews are really good for understanding complex interventions, which is what we might class link workers as. These are interventions that have a number of different components, a number of different actors, and a number of different outcomes. So as I say, our realist review set out to understand how link workers work, for whom, why, and in what circumstances. The review itself drew on the existing literature, and we included 118 documents in the review. Again, if you want to read more about it, we have published the review in BMC Medicine. I'm just going to give a very sort of broad brush of some of the key findings here. In terms of things required to ensure that link workers can perform in an optimum manner in primary care, our review highlighted that there needs to be this idea of buy-in. Buy-in to the role of the link worker as a viable alternative or as complementary to traditional medical care. And this buy-in needs to come from patients. So they need to accept that seeing the link worker is suitable to meeting their needs. But it also needs to come from primary care staff, particularly GPs, if they're the ones who are referring patients to the link worker. So GPs need to see link workers as credible sources of support for patients. The review also highlighted the importance of connections or partnerships in optimizing the link worker role. And this is in terms of the relationship between the link worker and the patient. Patients need to feel as if they can trust the link worker, so that then they can open up about their non-medical needs, and they are trusting the link worker to refer them to things that might help in the community. But the link worker also needs to be able to develop relationships with primary care staff and with those groups, charities, organisations in the community that they refer patients onto. So link workers need good communication, good people skills, and they need to be able to develop a good local knowledge of what's available in the community that they can then refer patients onto. We are due to start another new project on the link worker role this summer, and this is going to run for 30 months, so quite a big project. It's been funded by the National Institute for Health Research, and it's going to build on the review that I've just mentioned. It's going to aim to produce evidence-based recommendations on how to optimize delivery of link workers. And we're going to base it, the review was based on existing literature. What we're going to be doing in this new project is collecting our own data. And this is going to involve observing link workers in GP practices, and also talking to patients, talking to link workers, to healthcare staff, and to staff in the voluntary and community sector. Part of this research, we are working with colleagues from different universities, and we're going to be working with people from different academic backgrounds. So in that sense, the work that we're doing here is interdisciplinary. And I'm going to pass back to Kamal now, who's going to talk a bit more about this interdisciplinary nature of some of the work that we're doing.
Thanks, Steph. So one of the things that's really important that's happening in the NHS at the moment is increasingly this notion of integrated care. So Steph's just given you an example of how the social prescribing pathway may work. So let's just recap. So you may have a conversation, I may have a conversation with a patient in general practice and identify that there are potentially non-medical issues which are connected somehow to some of the medical issues, but that there may be other support available for this patient. I may then refer this patient onto the link worker, who then has a conversation with that patient, explore some of these other issues in more detail, and then starts to make a plan with them about how other resources can support them. Some of those resources, as Steph highlighted, could be in the community, and that's where often you'll find some of the resources that link workers refer patients to, and we often refer to those resources as community assets. So you can start to see a picture of how integrated care like this may well work. And of course, we can have then conversations with both the patient again and with the link worker to see how that's gone on. So mirroring this idea of integrated care, one of the reasons that our research has been so enjoyable and also so touchwood so fruitful is because we're also taking an interdisciplinary approach to it. So by that what I mean is Steph and I are health researchers, but we've been working very closely with other members of the community, other academics as well, with different backgrounds. So for example, from the arts and humanities, from the social sciences, from engineering and so on, just to identify our different skill sets and how we can bring them together in this research. And I'll just give you a couple of examples of how that's worked. Next slide, please, Steph. So collectively, through our partnerships, we've established the Oxford Social Prescribing Research Network. And there's our link to that. And again, I'll show you that link again at the end. But our concept and our vision is to improve health and well-being through interdisciplinary evidence-based research and innovation. And again, I'll tell you about some of the projects. Next slide, please. So one example actually stems from a speech that Matt Hancock, who's obviously a very busy man right now, but actually Matt Hancock has been a huge advocate of social prescribing. And I think that stems from his role as in the Department of Culture, Media and Sport before he became health minister. And this is a speech that we're going to highlight just about how he talked about the benefits of social prescribing, but also about how we can use various community-based assets to support patients' well-being. And I'll just tell you about a bit more how we've done that with one of our projects. Next slide, please. So in that particular speech, Matt Hancock highlighted the roles of arts and the cultural sector. So mirroring that, we at the Centre for Evidence-Based Medicine have formed a collaboration with our colleagues within the university in the gardens, libraries and museums, who are beautifully titled the GLAM Division. And what we did, we started looking at how can these environments, how can gardens, libraries and museums support people's well-being, and how can we incorporate that opportunity within NHS social prescribing pathways. Next slide, please. So as part of that program of work, there you are, it's just fading in. We first started to map some of the environments within the GLAM division. And here's a sort of a highlight of some of them. So the University of Oxford Gardens, Libraries and Museums Division, it's responsible for the Ashmolean Museum, the Bodleian Libraries, History of Science, Botanic Garden and Harcourt Arboretum, the Natural History Museum and the Pitt Rivers Museum. So these are all spaces and environments open to the public and available for use within their division. But also we were exploring in a bit more depth, how might they improve your well-being and how might they link to NHS social prescribing pathways, which previously hadn't been done. Next slide, please. Thanks. So here are some of the examples of some of the things and work that's been gone on within the GLAM division, particularly focused around well-being and health. So here's an example of, for example, the messy realities, looking at museum collections, medical technologies, and involving members of the community to come in, hear some of the talks, feel, touch some of the exhibitions, and just to kind of create a more social environment around some of the museum artifacts. Next slide, please. So what we did is to explore this in a bit more depth. So we started hosting in 2019 a series of workshops with members of the public and wider stakeholders. And we started asking these stakeholders, members of the public, how do you feel these environments can support well-being and health? What do you think they need to do, adapt, change to support well-being and health? But also, how might they incorporate themselves into the NHS in a very authentic way? And we held a series of workshops, as I said, and in the top row, you can see some of the workshop photos with members of the public. And in the bottom corner, you can see Steph and I holding a workshop whereby we were actually reaching out to stakeholders. So members of funding committees, clinical commissioners, policymakers, charity CEOs, and so on and so on. Again, asking them the same questions. Next slide. And what we did was we then triangulated, we synthesized all that information together, and we looked at the literature as well to get exactly that question, as I said before, how can gardens, libraries and museums improve well-being, and particularly with a focus on social prescribing? And some of the data that we came up with, both from the workshops and from the literature, is shown here. And we put them all together in a report, which you can see on the third picture there on that slide. So we identified that these environments can provide opportunities for knowledge and skill acquisition. They provide people with a sense of structure and purpose. They often allow social connections to develop, and they can provide relaxing and comforting environments as well. And then we asked the question, well, what is the mechanism through which some of these things can be gained? And we identified, and again, in that middle panel, that some of the key things that emerge are the notions of creating therapeutic landscapes. That's not necessarily just outdoor landscapes, but just the idea of creating therapeutic landscapes, creating a sense of flow, and being able to sort of just immerse yourself in the environment that you're in. And then the notion of drawing on social capital, which is around thinking about what collective strengths are there in the community and how can we draw on them for a greater gain. And as I said, if you want to read more about this, we've produced a report which is freely downloadable from our website. It's about 60 pages where we've sort of put all of this information together and presented it in a very more accessible way. Next slide, please. And again, we're speaking on behalf of Kellogg College. Both Stephanie and I are members of Kellogg College as well. And Kellogg College is no different to recognizing the importance of green environment in this case. So the college asked me to support their transformation of their grounds, which is taking place at the moment. Again, if you want to know more about that and how they're going to adapt their green spaces to support well-being, both for the college, but also the wider community, please contact the college and they'll tell you more about it. But again, just to think about how the college grounds in this case can be designed, again, using evidence-based ideas, thinking about well-being and health within the community as well. Next slide, please. So I said I'd tell you a bit more about very briefly, some of the other projects. So again, if you want to know more, here's our Oxford Social Prescribing Research Network website that's just been launched. There's the URL. And yes, so some of the projects that we're ongoing at the moment. Next slide, please. Here's one of the main ones that's actively going on. So we took that concept of thinking about the cultural sector and how that can support people's well-being and health. And we applied that in the last year to explore how can these centres, these environments, support people in the pandemic and more specifically the recovery phase from the pandemic, and specifically in terms of the population, older people. And so we've got some funding from the UKRI Arts and Humanities Research Council to explore this in more detail. And we're working with international colleagues, with members of the public, both in the cultural sector, from the health sector, and from the arts and various other communities, just to explore both through an evidence synthesis, so looking at the literature, but also through some primary data collection. So we're going out and we're interviewing various stakeholders to explore some of their experiences. And we should be hopefully producing our results very soon. We produce some imminent results, some intermediate results shortly, and also some final results and reports in a few months' time. Next slide, please. Again, just very quickly, some other projects that we're working on. So on the top left-hand corner of my screen, you can see we're working on a project looking at the role of volunteering in social prescribing. We get a lot of questions and discussions around the role of volunteering in general, but also thinking about how it can link with some of the work that we're doing in social prescribing, some of the link worker activities as well, and thinking about some of the benefits of volunteering as well. On the top right-hand corner, we've done some early phase work looking at the role of social prescribing for people diagnosed with mild cognitive impairment and how social prescribing schemes can adapt to support that population. And in the bottom right, a colleague of ours is working on a program of work around thinking about how rural communities can benefit from social prescribing as well. And in the bottom left, we're thinking about what are the ethics of social prescribing? What sort of things need to be considered around social prescribing and how it can be embedded and then implemented for the long term into primary care, taking into account some of the sensitivities that we may come across as well. Next slide, please. So, as I said, a lot of our work is based not just through the things that we do, but really, really embedded in our work with collaborators and the members of the public. So here's just some examples of some of our colleagues that we work with. Obviously, members of the public are central to what we do, and we have strong ties with and engagement throughout our programs of work. But we're also working very closely with NHS England, the Royal College of GPs, the King's Fund, various parliamentary groups as well, charities, local councils, and the new National Academy for Social Prescribing as well. Plus also within our own university, as I said, the GLAM Division, but also colleagues in psychiatry and Kellogg College as well. So I think if we go on to the next slide, thank you. That's my opportunity to thank you for listening to Steph and I. And again, there's our URL for our new website if you want to find out more about our work, or you can contact us directly. There's our email address. But yes, thank you for listening. And if anybody has any questions, we would happily answer them. Thanks very much for joining us at this Kellogg event.
Thank you.
Thanks.
Bye.
Thank you.
Thank you. Bye.